Well, good afternoon, dear colleagues. Natalia, thank you for this invitation to participate in your event. I will be speaking about comorbid patients with glaucoma from the point of view of a practical doctor, because this is a very relevant topic, the presence of different modern diagnostic methods, a variety of medical therapy treatments will determine, well, different excesses when more drugs are being administered, often without thinking about the status of the patient, the somatic status of the patient with comorbidities, and we treat the glaucoma, and as a rule, we administer the drug to achieve the specific pressure, because this is our main goal, and of course, not always we pay attention to important issues related to comorbidities. Let's go back to square one, and I would like to uh, go back to the definition of comorbidity when Professor Feinstein, at the end of the 19th century, said that, well, modern medicine is distinguished by an abundance of diagnostic methods, and comorbidity is the presence of an additional clinical picture that already exists or can appear independently in addition to the current disease and is always different from it. It can appear on its own, and it will be different from the main disease. Matvey Mudrov said long ago that when examining a patient, remember that at this time the patient is examining you. Speaking about comorbidities, when the patient has two or more diseases or different disorders, especially when they are linked by the same pathogenetic mechanism or coinciding in time. Of course, the age aspects of comorbidity do exist. We know that with age, the number of chronic diseases will increase. At the age of up to 19 years, it can be about 10%. At the age of 80 years and older, it will be over 80%, 80, and this determines the vicious circle, which is difficult to break. It starts with comorbidity, then polypharmacy, the administration of a large number of drugs, increase the likelihood of developing local adverse effects, which can be considered as the manifestation of one of the factors of comorbidities, and will result in administration a larger number of drugs, which reduces adherence to treatment and closes this vicious circle. Here you can see the data of the register in the Novosibirsk region, and you can see as for the primary open-angle glaucoma, we have a large number of the patients. The population of the Novosibirsk region is about 1,700,000 people. The age of the patient is shown here, and of course, at the age of 60 and over,
Age 60, 78% of the patients. And here you can appreciate the data of our patients' comorbidities. And together with glaucoma, they suffer from diabetes, bronchoobstructive diseases, ischemic heart disease, autoimmune diseases, osteoarthritis, neurological pathologies, arterial hypertension, and number of other pathologies. That is why doctor and patient with glaucoma, it's always important dialogue and polypharmacy. Unjustified prescription of multiple drugs and procedures today is a very common problem. And this is an interesting study which, in fact, analyzed the compliance of patients, 167,907 patients, and you see how they stick to treatment. Their compliance rate, unfortunately, prostaglandin analogs, for them compliance was just 47%, less than 50, and we see something which is even lower, something which is used in urinary hyperfunction, hypertensive, oral anti-diabetics, statins, they all had high compliance. Speaking about the structure of comorbidities, we should not forget saying that the leading one is definitely cardiovascular pathology, and this is 92.3% with the full spectrum. But these patients are getting also general hypotensive treatment. Here you see the spectrum of these treatments, but please appreciate that almost 40% are getting fixed combinations with beta blockers. And again, speaking about the long-term contact with the patients, that the treatment of glaucoma is marathon, but not a sprint, we should remember that, yes, beta blockers that we know for years value, used actively in practice of treatment of our patients with glaucoma, they are not so safe because by availability of ophthalmological timolol is similar to plasma kinetics and cardiopulmonary effects with IV administration. That makes it necessary to pay attention to such high bioavailability because intensive systemic beta blockers could be dangerous for our patients, especially if they're getting fixed combinations as the general cardiovascular treatment for the treatment of arterial hypertension. Speaking about metabolism of timolol, we can identify here several specificities of because there are extensive metabolizers that have normal gene of enzyme metabolism and the pace of metabolism within normal range. There are slow metabolizers and fast metabolizers. So the prevalence of slow metabolizers in Russian population is about 30%. 30% that definitely influences the results of our treatment. It is very clear that beta adrenoblockers in the combined anti-anginal, antihypertensive treatment is actually having particular percent, and these are about 30% of adverse reactions here. But in case of systemic use and the local use of beta blockers, the percentage of adverse events could reach 82%. Definitely, there are contraindications very well known for the treatment of beta blockers. These are cardiac diseases, COPD, chronic obstructive pulmonary disease, but this problem is a global one. And here you can appreciate very interesting data. This is a study carried out in the Netherlands, where, regardless the guidelines of using non-selective beta blockers in patients with COPD and bronchial asthma, in average, you can see here that in average 10 patients were getting monthly beta blockers to one outpatient pharmacy. So totally 827 patients were using non-selective beta blockers. And quite significant percentage of the doctors, it is shown in this study, either did not know about the comorbidities or didn't think them to be contraindications. So yes, the problem is quite general, but nevertheless, we should understand that they are lipophilic beta blockers. They could go through BBB, they provide neurological diseases. So yes, they have particular limitations in their use, especially in patients with diabetes due to the increased glycemia, due to the increase of insulin resistance and deterioration of the lipid exchange. So, and this potential interaction between the systemic and local beta blockers related with pre-existing blockade of beta-adrena receptors desensitization of ciliary body due to systemic beta blockers. At the same time, systemic antihypertensives, which contain beta blockers and use them at bedtime, definitely reduces ophthalmic nerve perfusion even lower. Dramatic drop of systolic blood pressure at nocturnal time increases risk of progressive glaucomic optic neuropathy almost 20 times. Ups and downs of diastolic pressure increases this risk in 5.5 times, and that potential interaction facilitates also a systemic reduction of the ventricular circulation, reduce synthesis of liquor, reduction of the intracranial pressure and the pressure in the optic nerve. That facilitates the progression and, in fact, leads to the uncontrollable course of glaucomic optic neuropathy, and progression and escalation could be even more sensitive to the minor reduction of the intracranial pressure. And it was already described by Professor Volkov. Still speaking about the influence of co-administration of systemic beta blockers on topical use of timolol, here you see a very big study. So totally 926 patients, and 66 of them simultaneously were getting systemic treatments. And it has been shown here much lower reduction of pressure, intraocular pressure, systolic, diastolic blood pressure. You see dramatic reduction of cardiac beats versus the patients who were not taking systemic beta blockers. That is why, yes, this is a long-term marathon, but not a sprint. And it should remind us that right now the main trends and tendencies related to the ophthalmic surface pathology, where in practice we intensify treatment and we are mainly focused on the reduction of the control of ocular pressure. Then tolerability, it's a secondary problem. And in 36%, the features of pathology of the surface related to treatment should be a signal to reconsider therapeutical approach and switch to the formulas which is preservance-free, because we always understand that patients with glaucoma definitely should have surgery at a certain moment of time. And definitely quality of life of the patients should not be underestimated. At the same time, autoimmune diseases, and they are also in the list of comorbidities. So they play a very big role, and this is a very big risk factor for the development of the dry eye syndrome. And the patients are getting not only beta blockers, they are getting also non-steroid anti-inflammatory treatments, number of other treatments that increase further on the risks of the dry eye syndrome, increased sensitivity of the retina and cornea, and worsen the situation. So this is data from our region. So all that allowed us to minimize for the recent years the percentage of timolol monotherapy. So in 2017, 12% were getting timolol mono, and in 2024, only 4%. So, and we managed to increase the percentage of the preservative-free formulas. So glaucoma treatment is, again, it's a marathon, but not a sprint. So this is a running for the long distance. So we have to put priorities. We have to treat the patients, but not the disease. We have to follow and to treat according to the physiological, but not chronological age. And the most important, to make a right choice, wise choice for the patients and together with the patients, because any success of the medicine definitely reflected to the success of ophthalmology, and any success finally influences the success of medicine in general. Thank you very much for your attention.